I welcome all the participants as well as our speaker, Dr. Sudhir Mehta.
Thank you, sir.
Before starting the webinar, we have a message from our Dean, Dr. V.B. Kharadi, sir, Dean and Principal of the Veterinary College, Navsari Agriculture University, Navsari. So, Dr. V.B. Kharadi, sir.
Good morning to all. I hope you all are safe and well at your place in this COVID-19 situations. We all know that due to the coronavirus, we all are under the lockdown period, which has affected the education of the students. But to mitigate this issue, Navsari Agriculture University, Navsari has developed E-class facility for the students under the guidance of Honorable Vice Chancellor Dr. Sunil Chaudhary. And I am happy to announce that all the teachers of Veterinary College used this facility and completed the remaining curriculum during the lockdown period, and also successfully completed the online examinations. In addition to this, our teachers, Dr. Deepak Suthar and Dr. Lalit Modi, also started NAU Webinar Series 2020 on the various topics on clinical aspects for the benefit of undergraduate and postgraduate students, field veterinarians, as well as the teachers. I appreciate that the efforts are made by Dr. Suthar and Dr. Modi to use this critical COVID-19 period very efficiently to improve the knowledge of the students and veterinarian working in the field through the digital platform provided by the IT department of the university. The Vet NAU website is not only useful for the Gujarat students and veterinarians, but also almost useful globally as per the participant registered in various webinars. I congratulate Dr. Suthar and Dr. Modi for the success of the Vet NAU Webinar Series 2020 and wish them the best of the luck for their future endeavor. Thank you.
Thank you, sir, for your motivation as well as the best wishes and regularly given the suggestion to improve this webinar series. Thank you very much. So dear participants, let's start our today's webinar, which will be delivered by Dr. Sudhir Mehta. I welcome Dr. Sudhir Mehta. Dr. Sudhir, please start the webinar.
Yes, sir. Thank you so much. Good morning to one and all. I welcome you on online webinar series, Veterinary College, Navsari Agriculture University, Navsari. Friends, we all know that this topic, canine renal dysfunction, acute kidney disease, chronic kidney disease, has been broadcasted many times online. And every time we are So this is so wide topic that more and more we learn, better we diagnose the condition. Dr. Modi, are you getting my voice? Okay.
Now start it.
Okay, fine. So, this topic is extremely important because 20 million is currently a dog population in India. And one research suggests that in in India, the incidence of renal diseases is 2.58%. And if we talk about the world, renal disease and renal death is world third leading cause of the death in canine populations. So that's why it is extremely important. And this is my small effort to update your knowledge. I know you all are the learned listeners, learned practitioner, and maybe the more experienced than me. So I'm trying to give a best whatever I know. So starting with the basic anatomy, we all know the dog has two kidneys lie against the back abdominal wall, and it is lateral to the spine, which can easily palpate externally. And person who is doing sonography, they may agree with me that left kidney is located caudally, and it is very easy to get as you keep the probe. There is no much probe adjustment is required. But the right kidney is something tricky. It requires the probe adjustment. It requires some experienced hand because it is the inside the pelvic cavity and at the end of right limb. But you can have this. It is located cranially to the head. To know the basic gross anatomy, we all know this is fresh off our knowledge. This is about the renal cortex, the outermost renal capsule, the outermost layer of the kidney, which protect it from the external shocks, external environment. Then this is middle layer is renal cortex, and this renal cortex has a very large amount of nephrons. And inside there is a renal medulla, and inside the renal medulla there is renal pyramids. So this structure is well recognized when you do the ultrasound of the kidney and has to be appreciated separately. So that is a good image of the kidney. And this whole white portion is known as the renal pelvis, where the urine is formed, and through ureter it is transported to the urinary bladder. Now this is, you all know, the nephron, functional unit of the kidney. Each nephron has a numerous functions, and each kidney are having more than 1 million nephron. As I told you, it is the two type of the nephron, cortical nephron and medullary nephron. 85% nephrons are located in the cortex, and 15% nephrons are located in the juxtary cells of kidney, that is in medulla. So the main function of nephron is to absorb and filtrate the metabolic waste. And in spite of having 1 million, two kidney composed of 2 million, but this is I should say a negative sides of the kidney. Why? Because kidney is an extremely sensitive organ, and God has gifted a very good compensatory mechanism. If 20 million nephron has been lost, then remaining 80 million will cope up the function. If 50% nephron has been lost, remaining 50% will cope up the function. So that's why, and in certain diseases, certain condition, if the one kidney is lost, the one kidney will functioning well, the dog has no clinical signs. That's why the renal diseases clinically exhibit very late, and that's why because it regulates the many things in our body. There are two terms generally spoken. One is the renal insufficiency and renal failure. So theoretically, it can be defined if there is a more than 70% loss of the functional mass. Ultimately, there is a loss of contracting ability of the urine, and ultimately the urine is become diluted. So if it's 70% loss, then you can tell it's a renal insufficiency. But if it is a 80% loss, then it's loss of ability to excrete the waste product which is accumulated in the body, leading to the azotemia, and diluted urine if the animal is well hydrated. Then you can say is a renal failure. So again, in clinically, it is somewhat difficult to identify the acute renal failure and chronic renal failure. In my subsequent slide, I will emphasize on this aspect also. But again, this is some basic idea. But theoretically, it has been said the renal insufficiency, and if there is no azotemia, then you can tell is it a renal insufficiency. But if azotemia is there, you can tell it can be a renal failure. There are certain risk factors. The most of practicing vet have come across with this risk factor which may lead to kidney diseases. The first and foremost is age. When the dog is more than 7 or 8 years of age, it is more prone to the kidney diseases. And the smallest age where the kidney is accorded is less than 4 years of age. But if it is in younger dog kidney disease, you have to take a biopsy and rule out the other causes. Then gender. Generally, there is no very specific that males and females are having more important prevalence of kidney disease, but females are higher because of the pyometra and sepsis rather than male. Male also it is seen, but that's why it is not very specific, gender specific disease. Again, it is not so a very breed specific disease, but compared to the data, it is suggestive of Labrador followed by German Shepherd and Pomeranian have a very much high records of kidney dysfunction. And diseases like systemic infectious diseases, cardiovascular diseases, and obstructive diseases like urolithiasis and all that will contribute to the kidney functions, kidney dysfunctions, and ultimately they may develop an acute kidney injury and later on may develop to the chronic kidney injury. Food is also a very important part which contribute to the developing kidney disease or preventing the kidney disease. See, nowadays people have keeping dog as a pet, not only pet, as a family members. The dog is sleeping with him, dog is eating with the family members. So whatever they eat, they will offer to the dog. The dog has different food patterns. So they are adopting human food patterns that may be rich in protein, that may be rich in phosphorus, they ultimately develop the kidney disorders. And managemental, that is obesity. Obese dogs are more prone. Any kind of physical trauma to the kidney or maybe the accidental automobile operations that may imbalance the electrolytes, that may imbalance the homeostasis, that may ultimately contribute to the kidney disease, and any kind of poisoning that also may lead to a kidney dysfunction. These are, somebody asks, whenever the kidney disorder diagnosed, we say that your dog has damaged kidney, that people is used to ask, sir, why it is happened? It is a common question, it has been asked in our clinics also, so why it is happened? And it is naturally, they are saying that, sir, we are keeping dog only in our observations, we are giving the best of food, why it is happening? So these are some of the etiological agent which has been identified by the researchers, and I have put it cumulatively here. So if it is infectious, it could be bacteria if we talk about the leptospirosis. In our area, there are a lot of cases of leptospira. South Gujarat is I should say the hub or the belt of leptospirosis. So we are getting in our clinic every 2 to 3 in every week we are getting 2 to 3 positive cases of leptospirosis in dog as well as in cattle buffalo, and that may lead to a pyelonephritis. So these are the probable bacterial reasons causing the kidney dysfunction. Hematopoietic disease, of course, borreliosis, E. canis, varicose, this is also responsible for kidney dysfunction. Viral, any viral disease is not yet established, but somebody said that the canine adenovirus can also cause a kidney dysfunction. Then come to the systemic causes where the sepsis, pyometra, septicemia, that may lead to kidney dysfunction, urolithiasis, nephrolysis, hypercalcemia. So these are the systemic effect on the kidney, and ultimately it may get dysfunction. Apart from that, the drugs that being used indiscriminately in the field practices, that may lead to a kidney dysfunction. Aminoglycosides are very rarely used, but sometimes used in the control of diarrhea and all that. So that may lead to kidney dysfunction. SE inhibitors, NSAID, and radiographic agent. So this is not a single time will damage the, if it is continue for a prolonged time, multiple time, or a multiple times over the period of 2 to 3 years, right? See, every 3 months, if it is getting NSAID, every 3 months, if the SE blockers is continued for a 2 to 3 months, that may lead to a development of kidney dysfunction. And finally, the renal ischemia, shock, infection, and pancreatitis can cause the kidney dysfunction. These are the cumulative reasons. Each are not very much specified, and each is not a single reason which can contribute. It is a multiple factor, but these are some basic separation that how it occurs in the kidney dysfunctions. Now, how we can identify a dog when it is presented to us in our clinic? These are the general signs. If a dog are presented with this list of the signs, all the signs may not be present in all the cases, maybe combinations, 2, 3, 5 signs clinically it is exhibited, then we can think for the kidney disease and we should prescribe some laboratory test and some kind of urine analysis and all that. So among them, persistent vomition. This is a very classical example, classical clinical sign exhibited in acute kidney function. When presented to us saying that, sir, my dog is vomiting 4 or 5 times and it is not getting controlled. If it is in gastritis, if you give a ondansetron and pantoprazole dose 2 times in a day, morning and evening, definitely the frequency of vomition is reduced, right? If it is a gastritis, and it should be stopped at the second day. But if it is not stopped, continue for 4 or 5 days, then definitely you should think for either liver is damaged or the kidney is damaged. Then polyuria, urinations exhibited by the dog, and that is noticed by the dog actually. That is noticed by the owner. Owner will say, sir, it is taking too much of water and every time it is going urinating. So polyuria is the first sign where filtration is altered. Filtration is altered at the glomerulus. That you have to think. And we should think for further diagnostic test. And then it is ultimately, if it is a oligouria, when it is presented late, it is having oligouric condition. Various degree of dehydration that can be determined by a certain test. Then anemia is also there. Lethargy. Animal loses vigor. By looking the animal, you will have the idea, yes, it could have the kidney disease. It is sitting on the one positions, laying lateral recumbency, not very active, like boredom. So this kind of lethargy is observed. Halitosis is also there. Paresis is also there. For a hindquarter weakness, the animal is not getting the walk for a few steps and then sit down. So paresis is also there. Then hemorrhages on buccal mucosa. That is very important. Petechial hemorrhages you may find in buccal mucosa. And if you observe tongue, then the border of the tongue, it is having edges. It is having a serrated border of brown color, maybe reddish color. So that is hemorrhages due to the uremic toxin that is accumulated in the body. Some of the dog are having bloody diarrheas and melanas. So these are some clinical signs. Apart from that, edema of hind limbs and ascites. So this is also a very classical signs where we should think for the kidney is damaged. These are some picture for representation. Pain on palpation. If it is an acute stage, you palpate the sublumbar region, you will find the pain. Animal elicit the pain, so that indicate, yes, it is the maybe a nephritis that is there. Then there will be an anemia. So in this situation, you will find the whitish color of buccal mucosa. You can also judge by the capillary refill time, so that can be determined. Then buccal congestions, maybe some kind of hemorrhages you will observe in mucosa. That is also indicative. Skin tinting, a very much practical test for the dehydration. Do the skin tenting as neck area or maybe the abdomen area. If it is tenting, it is naturally a dehydration. We all know that. Polyuria reported by the owner and ascites. So these are some classical signs. But if you look this slide in your dog, then the dog should have some kind of kidney damage. Now we come to the diagnosis. So these are the list of the diagnoses. By you should go one by one and eliminate the causes. The urine analysis. Generally, we only rely on the blood and serum biochemical parameters, but the kidney filtrate the urine. So the filtration is urine. Whatever you are getting, that is very important part of the that kidney health. If the health of kidney is good, the urine quality is good. So the urine is a end product of the kidney functions. So if it is damaged, definitely they're having an alteration in the urine analysis. And it has been said that alteration, whatever taking place in the blood, it has to be exhibit or it has to be exist in the urine of the particular dog. So blood abnormality comes later. First, the urine abnormality comes first. So we have to always check the urine of dog suspecting for the kidney disease. And it is, we all know, non-invasive method of assessing the function of the kidney. The fresh urine should be collected. The urine should be collected either by the voiding, if you have observed or the owner has observed, the mixture of urine has to be collected, or can be collected by use of catheterizations, or it can be collected by the cystocentesis also, direct holding the bladder and having the puncture from external side and collect from the syringe needle. So cystocentesis, you can also collect the urine, and this is actually the best method, but it may have some chances of infection sometimes. So that's why direct voiding or maybe the catheter or the cystocentesis, you can collect the urine. By whenever we have the urine, we have to see the certain things. Among them, first is color. Generally, it is often yellow color due to the presence of a urochrome pigment. It will give the yellow color. But when it is its water, kidney will not a deep yellow color. So if it is a deep yellow color, you should think that it may have the dehydration. And if it is colorless, colorless is definitely a diluted urine. Nothing is getting reabsorbed, everything is getting out. That is called isoturia. Right? So that is an isoturia, and it is having diluted urine. So when you are hydrated, when you are well hydrated, the dog are having the rather than yellow, it is having the whitish color. So that is of signs of that dog is now hydrated. But if it is a yellow, okay, it is a moderate color of the urine. So you have to observe the urine color, and you have some idea that whether it is dehydrated or whether it is diluted or what the condition is. Volume is very much important. Dogs generally urinate 25 ml per kg body weight per day. So if it is less, it is known as anuria. If it is less, it is known as oliguria. If it is polyuria, that means 2 ml per kg per hour. It is considered as an polyuria. So it is seen in early stage of the kidney disease. Oliguria, later stage, you may find there is a less production of urine, and finally when kidney is non-functional or end stage kidney, there is anuria. If anybody said that, presented to you with the cachexic bone conditions, I don't know when it is last urinating. Definitely it's a case of chronic kidney dysfunction. Specific gravity is very much important. You can do all this test by either refractometer, or you can send to any laboratory, human laboratory, they will do this test. Or you have the urine dip test, which is available, urine test and all that, commercially available. We can use it and they will tell you the figure. So specific gravity, generally it is 1.15 to 1.30. Right, it may normal specific gravity may reach up to 0.70 also. In earlier stage, it is increase up to 0.50 to 1.50 to 1.76. If in between you may find the specific gravity, it is a 5% dehydration is assumed, and in increase in later stage also, earlier stage also, because of proteinuria. So you have to see that why the specific gravity is increased. If the specific gravity is too high, that should be high protein. But if it is between 0.50 to 76, it is indicative of 5% dehydration. But it is very much decreased because the urine is getting diluted, nothing is getting absorbed. So it is decreased in case of later stage of the kidney disease or end stage of kidney disease. pH of the urine is very much important. Certain things you can identify by the pH. If the pH also represents the blood pH. Urine pH is also a very approximate idea. You will give the approximate idea about the blood pH. So it should be 5 to 7.5. We all know the canine urine is acidic urine. So the pH should be between 5 to 7.5. It is decreased in case of acidosis, protein-rich diet. It is increased in case of UTI, if diuretics is going on, or maybe alkalosis it is there. So this pH is important indicator, particularly for the leptospirosis. If you find the pH may be 8, pH may be the 9, it is indicating of alkalosis, it's okay. But it's also indicating of the presence of leptospira in the urine. You should send the urine for the dark field microscopy or maybe the spot diagnostic test available for the leptospira. You can rule out these things. So pH is also important, and that pH, if it is acidic, more acidic, that indicating of the maybe the plasma buffer is less and blood pH may also elevate. Then glucose normally not present in the urine of the dog, but when it is crossed 180 milligram per deciliter, it is a renal threshold where there is a diabetes mellitus, right? Otherwise, urine up to the 180, it maybe you can consider as a normal, but it is getting excreted when the blood glucose exceed the 180 milligram. So when blood glucose is more than 180, maintain the glucose, they will reabsorb and send it back to the system. But if it is more than 180 milligram blood glucose, it is excreted in what we call a glycosuria. Then comes to the blood, it is generally not present, but if it is a hemoglobinuria due to the hemolysis or autoimmune reaction, it is there, or maybe the physical trauma, maybe due to the stone or maybe due to the any kind of physical trauma, it may having the hematuria. That can be different hemoglobinuria. Then comes to the protein. It is a very stress amount, less than 50 milligram per deciliter is there in the urine. But it is very much important that you should look for the protein in the urine of the dog if you are suspecting kidney disease. If it is higher, if it is higher, it is suggestive of a renal damage, glomerulonephritis, cystitis, or urethritis. These are actual renal causes. And in non-renal causes that we talk about the protein loss enteropathy, that is hemoglobinuria or myoglobinuria, heavy exercise and diet. So protein is a very important part of the urine that you should look for and you should observe. If it is higher protein amount, it may be a glomerulonephritis, it may be a protein loss enteropathy, and renal damage is there because protein generally not pass the glomerular. It is having the high molecular weight. So if protein is higher, it is suggesting that glomerular permeability is altered, and that's why it is passing in the urine. It has been said that increase in urinary protein excretions correlate with the decrease in survival independence. That means you should decrease the urine protein excretion by ways and means. If you are not able to control, it is one of the cause for the death in case of canines, because it is decrease the survival rate and independent of any factor. And it is also said that proteinuric renal diseases progressively more rapidly than the non-proteinuric diseases. So how we can measure? One, we can measure by refractometer. So that will give you actual urine protein value. And one correlation has to be established with the creatine. That is very much important. That is known as the UPC, urine protein creatine ratio. You can have by this formula, you will have the urine protein value and you will have the value of urine creatinine. Both can be obtained by the refractometer, or that can UPC test can be done by any lab, any human lab, and they will give you the value. So if it is less than 0.2, you're not about to worry about the kidney. It is non-proteinuric. Wait, observe, take the again test after 4 or 5 days or after a week. If it is less than 2, nothing to worry. If it is between 0.2 to 0.5, you should think of it is a borderline proteinuria. And if it is greater than 0.5, yes, the cause could be renal. You should think for a renal diseases if the proteinuric dog is there. UPC is a very good indicator of a glomerular dysfunction or glomerular filtrations. So that can be taken consideration while in the diagnosis. Then comes to the microalbuminuria. That is abbreviated as AMA, because nowadays in human medicine also the people is doing, doctor is prescribing this test for the microalbuminuria, and it is also there because when the protein is loose, naturally the albumin is loose, but it is a very much sensitive than the UPC. If the UPC is less than 0.2, as we have discussed, non-proteinuric, then you should also do the microalbuminuria. If there is a microalbuminuria, then it is indicated that it may progress to the kidney dysfunction, because microalbuminuria testing may allow earlier detection of reduced GFR, because GFR is reduced. And why? As I told in very earlier, if the 20% nephron has lost, GFR is not getting reduced because it will cover up by another 80% and another 1 million nephron which is there in the another kidney. So it should be detected at a very earlier stage. So if you are detected at a very earlier stage, you can recover it very earlier stage, and dog may have the very good quality of life. So the microalbuminuria is a very good indicator of reduced GFR and localized damage to the particular nephroid segments. So it has 3 different causes. If it is a pre-renal microalbuminuria, pre-renal, that means before the blood enters to the kidney, it could be due to the hemoglobinuria, maybe the myoglobinuria in urine, and hypertension, or high blood pressures, hyperadrenocorticism, which is also there. Whenever kidney dysfunction, you have to take the glucose, right? If there is a diabetes mellitus, then you have to treat first. If there is a hyperadrenocorticism, then you have to also treat that. So these are 2 underlying causes for the kidney dysfunction: hyperadrenocorticism and diabetes mellitus. And of course, if it is a fever, at that time there is also an increase of a microalbuminuria in the urine. So if you eliminate this cause by doing certain tests, as I discussed in whatever urine test that we have, physical examination of urine, so it will give you the clue that it is not a pre-renal. Then comes to the post-renal, that is in the bladder. Maybe prostatic enlargement is there, prostatic abscess is there, or maybe the urethra are having some stone, or bladder are having some stone, maybe the urethra are having some stone, or bladder are having stone. So this post-renal causes, infection, stones, inflammations, and neoplasia. So if disease can be ruled out, it can be trauma, can be ruled out by the presence of blood in the urine, RBC in the urine. If there is infection, there should be the septicemia, there should be the leukocytosis, neutropenia, what we call a stress leukogram. If there is a stone, that can be differentiated by maybe the cast examination or crystal examination, or maybe in the ultrasound. Inflammations, that can be done by another test. I will tell you what can be done. Neoplasia, that can be visualized in maybe in the ultrasound also. So if you rule out this cause, it could not be a post-renal. So pre-renal, post-renal can be ruled out if there is a microalbuminuria is present. I am talking about very early detections of the that damage of reduced GFR or renal nephrons. Then comes to the renal origin. So if it is not there, how can confirm? It is less than 10 RBC per HPF. So it is indicative of there is no any kind of trauma, there is no hemoglobinuria, right? There is no hematuria. So it is less than 10 RBC per high power field. It is suggestive there is no trauma, there is no what we call hematuria, and less than 5 WBC high power field, indicating there is no UTI, there is no any kind of inflammation, and there is no any kind of infection. Then it is definitely a renal origin. But if renal cause, if the WBC count is high in the urine itself, then it is indicating of maybe a localized nephritis or maybe the UTI. So that's why you can differentiate the causes of microalbuminuria. But if you find the microalbuminuria in the urine, it is definitely indicating of a renal damage or a damage to the nephron. So as I told you, it is an extremely sensitive diagnostic marker over the UPC. So before you do the UPC, you have to do the microalbuminuria, or you do parallel. You do UPC also, you do microalbuminuria also. So you have to comparative values whether UPC is there or not. Recently, in one dog, presented in our clinics, and having the persistent vomiting since like last 4 or 5 days. Then we have seen collected the blood, everything was normal. HB was around 9, but there is a thrombocytopenia. There was I think 1,53,000 platelets was there. And in that dog, we have collected the serum biochemistry for the creatinine, burn, and total protein, everything. But everything in normal reference value. There was all in normal reference range. Then we do the UPC. So in UPC, there is too much high. The urine protein creatinine ratio was around 13. That means it is the data showing the urine protein is 650 milligram per deciliter rather than 50 milligram per deciliter. So, and at the same time we also do the microalbuminuria. So microalbuminuria was 5. So it is indicating that there is no change in creatinine, there is no change in burn, there is no change in protein, there is no change in HB. But even though the UPC is suggesting of a renal damage, then we have sent the sample for the examination, smear examination of the parasitology department, where it is confirmed as an Ehrlichia canis. So that could be a reason that we have doubt for the any kind of hemopotozone disease. So that could be a reason for developing of that abnormalities. So talking about the UPC and microalbuminuria is very much important, because it is also said that greater than 50% of critically ill dogs are having reported microalbuminuria. So if it is less than 2, the value of microalbuminuria is less than 2, it is considered as a negative. If it is 2.5, it is borderline. You have to also observe the patient for a week. And if it is 2.5 to 20, it is based on the color strip, the color developed on the strip, and you can match with the color code given by the strip maker. And we can have the amount of albumin in the urine. And if it is more than 20, 28 and more than 29, then microalbuminuria has no value. That means if it is more than 30, you have the value more than 30, then microalbuminuria has no value. You have to always see the UPC. That's why I tell you that before doing the UPC, there is a change in the microalbuminuria. So it is a very extremely sensitive diagnostic marker of renal dysfunction or a glomerular dysfunction. Then of course we have to see the cast, and that can done by any kind of pathology laboratory. Human pathology lab can do all this test. They will also tell you about this cast. See, this hyaline cast and granular cast are usually present in the urine of the dog, but it is only 1 or 2 numbers. It is normally present. But when the number is increased, due to the presence of concentrated urine. In concentrated urine, the hyaline cast and granular cast is increased, and it is indicating of renal impairment. When you find the granular cast, in this granular cast, there is an acute kidney damage. It is a hallmark of acute kidney damage, or having the ischemia due to the protein-induced nephropathy like hemoglobinuria, myoglobinuria, or any kind of nephrotoxic drug. Epithelial cast you may find due to the cystitis or maybe an acute nephritis. Fatty cast, that is in the diabetes mellitus. If there is erythrocytic cast, that may be the hemorrhage in kidney due to the presence of any kind of nephrolysis. Due to any kind of nephrolysis in the renal medullae, it is maybe the erythrocytic cast you are observed. Then maybe the leukocytic cast suggestive of any kind of inflammation and sepsis. So these are the photographs of certain kind of cast. That is all for our knowledge, otherwise it can be given by laboratory people. So these are the hyaline cast, these are granular cast, these are the epithelial cell cast, this is lipid droplet. You can find the diabetes mellitus, erythrocytic cast and leukocytic cast are in case of sepsis. So this much very good information we can available from the urine. So urine is a very much important for canine kidney dysfunction to diagnose. So we have to always take the urine analysis and then we switch over to the hematobiology. So if we talk about the hematobiology, then it is having the normocytic, normochromic and regenerative anemia. That can also be given by laboratory people, whether it is a regenerative or a non-regenerative based on the reticulocyte count. But in acute form, it is a normocytic regenerative anemia, and in chronic form of kidney disease, it is non-regenerative anemia, and it is having also a severe form of anemia. You may find the HB 5, 6, 7, maybe 4. PCV is usually increased because of dehydration, and the stressed leukogram, where the neutrophilia and leukocytosis, it is suggestive of sepsis. So these things you have to look in the hematological parameters. And finally, thrombocytopenia. Never miss thrombocytopenia in doubtful for the kidney dysfunction. You should always see what amount of platelets is there, whether it is adequate, whether it is less. If you have the number, then see it should be more than 2 lakhs. If it is thrombocytopenia, it could be a hemopotostone infection in the body that may damage the renal disorders, and ultimately the kidney dysfunction will progress. So these are some important parameters that we will look for in the CBCs. Now come to the serum biomarkers, serum biochemistry. These are this set of the tests you have to always done: BUN, creatinine, sodium, potassium, phosphorus, calcium, and total protein. So that will give you the picture of the hemodynamics, whatever are altered due to the kidney dysfunction. So that is very much indicative, and we should always go for this test, set of this test, whenever the kidney dysfunction we are expecting. The urea and BUN. We all know these are two words, but these are the same, I should say. And this is some of the time we are getting confused whether what value has to be taken, whether urea or BUN. Actually, BUN, it is a nitrogen content of urea in the blood. That is a nitrogen content of nitrogenous weight content, that is urea in the blood, and urea is a main molecule which is there in the blood. So urea you have to consider always, otherwise it is only a mathematical difference. It is, we all know, it is the end product of ammonia, which is produced with the protein catabolism and filtered by the glomerulus of the kidney. So it is 2.40 times than the BUN. So BUN is 10, naturally the urea is 21.4. You have to consider the urea, either you consider the BUN, because in United States it has been said BUN is popular, and in the rest of the country urea is popular. So we have to consider either one of these, but if you consider the urea, it is better. So you have to always consider the value of either of these, but it is an insensitive indicator of reduced GFR. By doing BUN, you cannot have much idea. Why? Because when GFR reduced by the 15%, glomerular filtration rate, when it is reduced by 15%, at that time, the BUN crosses upper limit. So when you have the BUN elevation, maybe 100, maybe 60, maybe 80, at that time you should assume that the GFR reduced by the 15%. So that is very late you are diagnosing the condition. And BUN is also having the another factor like dehydrations, like protein intake. So it has some factor which may elevate the BUN value or a urea value. So it is an insensitive indicator of reduced GFR. You should not rely on BUN, but if it is elevated, yes, you should rule out the protein intake. If it is not there, you should rule out any kind of dehydration. If it is there, and if it is due to the kidney disease, yes, that is important. Otherwise, it is not much indicator of kidney dysfunction. Then comes to the creatinine. We all rely on these 2 kilometers, creatinine and BUN, but we should think for that other value that we have discussed, that UPC and microalbuminemia, because it is very much important. Comes to the blood, creatinine is we are taking in consideration, but I should say we should not rely on creatinine. We all know creatinine, it is the produced from the dehydration of creatine and dephosphorylation of phosphocreatine in the muscle. The major 85% of creatinine, it is from the muscles, right? So it is also affecting the muscle mass. So the muscle mass, if it is higher, the body obese animal, it is that muscle mass is high, you may find the creatinine value 1.2. So that is not actually the creatinine due to the kidney damage, that is due to the high muscle mass. It is a specific indicator. When you find it is, why it is specific? When creatinine higher, you should think for a kidney disease. If it is 1.5, 1.8, 2, 2.5, definitely the kidney damage is there, but it is less reliable. Why? Because it is getting elevated when 75% loss of functional nephron, 50 to 75% loss. When it has been said that when 50% GFR is reduced, then 50% GFR is reduced, creatine value is getting double, right? And when it is damaged 75%, it is again double. When it is getting further 12%, it is again double. So it is ultimately when the loss is higher, at that time the creatine value is increased, and loss is higher due to the reduction of GFR. So it has been said that the GFR is has the relationship, exponential relationship with the creatinine. When it is decreased, when GFR is decreased, at that time the creatinine is increased. But if the GFR is not decreased, it is normal, then creatine value is normal. So you thinking, yeah, because I told you that GFR is not reduced because 25%, 40%, maybe the 50% nephron has lost, but another nephron has cope up with that function, so GFR is not reduced. At that time, creatine value will not be elevated. So the normal creatine value can camouflage the renal environment in clinical practice. That's why it is, of course, specific. If it is elevated, kidney damage is there, but it is not reliable. If it is normal, then you should think for other parameters to evaluate the kidney dysfunction. These are some of the reference value of the solute for ready reference you can have, and you can compare with your result. Now, another complications of kidney dysfunction, that is hyperphosphatemia. All my practicing friends have come across with this condition, hyperphosphatemia. Why this happens in the body? Generally, the phosphorus, it is not water generally getting damaged, because whatever it is phosphorus balance, it is phosphorus pool rather than phosphorus balance. Phosphorus pool is maintained by amount of phosphorus taking inside intake in form of food, and that is getting excreted. It is not getting altered. But when phosphorus is usually excreted by the distal part of the tubules, the collecting tubule and distal connervating tubule. So if the GFR is reduced, glomerular filtration rate is reduced, ultimately the excretion is decreased, and due to that excretion, the phosphorus is getting increased. At the same time, animal is not anorexic, they are not taking food, so the intestinal absorption of calcium is poor. Right. If the intestinal absorption of calcium is poor, ultimately, and along with the renal damage, because there is one enzyme in the renal which convert the inactive form of vitamin D to the active form of vitamin D3, that is called a 125 dihydroxy called calciferol, which is known as calcitriol. So this conversion is based on the kidney health. So kidney is damaged, calcium is less, so there is a less conversion of this active form to the inactive form to the active form. Ultimately, the calcitriol is reduced, and that's very, very bad signs for the kidney damage. When calcitriol is reduced in the body, the parathyroid hormone is a compensatory mechanism. Kidney has a all compensatory mechanism. When calcitriol is reduced in the blood circulations, at that time it will give a signaling to the pituitary, and that will secrete the parathyroid hormones. So parathyroid hormone will start compensatory. What will do? Parathyroid will start renal excretions of a phosphorus and absorption of a calcium from the bone, that absorption from the calcium from the stomach. If it is not there, then that is reabsorption from the bone. Then there is a mobilization of calcium. So that is called a demineralization of bone, and ultimately that mobilization will getting mineralized to the other soft tissues, and what we call a rubber jaw, and the chronic abnormality it is seen due to the hyperphosphatemia. So that is most common complications, hyperphosphatemia. So hyperphosphatemia is generally exhibited of that mineralization. Mineralization, if you take an X-ray, the some of bone are getting mineralized, particularly rubber jaw, it is getting highly mineralized. So this is another complications of renal dysfunction. Then hyponatremia, that we already discussed, but just for having idea about this, that is all that is called a RAS system, renin angiotensin aldosterone activation system. Whenever there is a extracellular fluid depletions due to the hemorrhage, due to the sodium, or due to the water reduce, right, in the body, there is a less water in the ESF, then osmolarity, because concentration will be there, so osmolarity is increased, and due to that there is activation of thirst center. That is first, the animal may drink water, water intake will be there, and the water level is increased, ultimately it is stable. But it is not stable, then another mechanism will start. It will give a signaling. Baroreceptor of carotid artery will give a signal, there is a blood pressure is low, then it will give a release of a antidiuretic hormones. So that when ADH is released, it reabsorbs the water as well as the sodium from the collecting tubule or a distal part of the convoluting tubule, distal part of the nephron. So it is absorb the water as well as the sodium from there, and ultimately the osmolarity is maintained, blood pressure is reduced, and sodium level is maintained. So sodium is extremely important to maintain the plasma buffer as well as the urinary buffer. So if it is not there, these are two compensatory mechanisms. Ultimately, what happens if the sodium is less in the body? There is naturally, due to the less water intake, because if you take water, naturally sodium you are getting along with that. So if the less ECF volume will be there is a less cardiac output. If there is a less cardiac output, there is naturally a renal infusion which trigger the secretion of renin, and ultimately, as we discussed, renin-angiotensin will increase of aldosterone, and sodium reabsorbs from due to the under effect of aldosterone, and sodium osmolarity is being maintained. At the same time, whenever there is less, the proximal part where the maximum 85% of sodium it is absorbed from the proximal part of nephrons, proximal convoluted tubules, it is absorbed. So that getting absorbed more, but some parts should be absorbed from the distal part. So when it is imbalanced, at that time there is a imbalance of electrolytes, and ultimately the blood pressure, the cardiac effect has been shown, and the blood pressure is reduced. So these are the hyponatremia is a very important part of the kidney dysfunction that we should always consider. Then comes to the hyperkalemia. It is always hyperphosphatemia is always there. Maybe hyponatremia may or may not be there because it is a compensated by the either release of aldosterone, either release of intake of water, or can be managed by the kidney itself. But hyperkalemia can be exhibited. As we all know, the potassium can only be excreted by the kidney. There is no another regulatory mechanism on potassium. It has to be excreted from the kidney. If the kidney is damaged, that is ultimately reabsorption of there is not excretion of the potassiums, and that is getting retention in the urine. Ultimately, it is retention in the blood. It is generally maintained by the level of ADH hormone, aldosterone secretions, and the distal flow rate, because at the distal part there is a potassium is getting excreted, distal part of the nephron. So if the distal part of the nephron has low flow rate, right, there is potassium and is less excreted. Well, the distal part of the segment of the nephron is damaged, ultimately the potassium is less excreted, as well as the ADH is less. And ADH, the low aldosterone can be the reason due to the diabetes mellitus, due to the use of SE inhibitor, NSAID, or maybe the use of beta blockers. So that can lead to a low aldosterone level. Ultimately, there is a high potassium level in the body. So hyperkalemia is a consistent finding in advanced stage of the kidney disease. It is a very prominent, and we might come across with each and every chronic kidney patients. Then we come to the SDMA. It is a very popularized nowadays and very important serum marker because it is extremely sensitive marker of kidney dysfunction. In our in human being, there is a formula based on serum creatinine and urea value. You will have the rate for the GFR, glomerular filtration rate. So that can be determined. In our veterinary patient, GFR cannot be determined because it is clinical practice. It is somewhat difficult because creatinine clearance and all that insulin giving, and this is somewhat difficult. But when SDMA, it is a classical example of a reduction of glomerular dysfunction, glomerular function when it is filtration is reduced. How much is it? Is the 25% loss of the function. When GFR reduced 20 to 25%, it will, when there is a function loss of nephron 20 to 25%, it will show elevation. That's why it is a very sensitive indicator of kidney dysfunction. And nowadays in India, one IDEX laboratory has launched the testing of the SDMA. It is immunoassay based on ELISA, but for that you need a reader. The IDEX reader is also required. The cost is, I think, 1,000 rupees. In many developed cities like Bombay, Pune, Madras, and in our Ahmedabad and Rajkot also, we have the IDEX reader. So if it is available, it is a very good indicator of a kidney dysfunction at very early stage, because it is not influenced by muscle mass, it is not getting influenced by anything. Right. So earlier detection of a progressive kidney function loss as well as the concurrent diseases having the can have the idea about the SDMA. So it is a very important test to be done if it is available. Then comes again to the urinary marker. So that marker can also be done by some of the human laboratories, but some of the human laboratory can do this test. I have listed few of the markers that cannot be available but can be available, like the albumin. It is a very indicative of microalbuminemia, what we have discussed. So that can be done by the any human laboratory. So that can very well understood what are the level of damage. Another is the C-reactive protein. So nowadays it is also popular in the human medicine. Wherever any kind of inflammatory change takes place in the body, the C-reactive protein is getting increased. So you do the serum C-reactive protein as well as the urinary C-reactive protein. If the serum C-reactive protein is increased, it is suggestive of any kind of nephritis. But if the urinary C-reactive protein is there and it is elevated, then it is definitely indicating of a glomerular alteration, because as it is mentioned here, it is having the 115 kilodalton of size, so that C-reactive protein cannot pass through the glomerulus, but when it is passed through the glomerulus, intact glomerular barrier, it is seen in the urine, it is definitely indicating of a glomerular dysfunction. So if you are not able to do the SDMA, you can do the C-reactive protein from the urine as well as the C-reactive protein from the serum. Apart from that, these are the very extremely sensitive urinary marker like SDMA, that NAG and GGT. So it is a very indicator of this kind of disease like pyometra, glomerulonephritis. It very help in very earlier detection. So if human laboratory is detecting NAG and GGT, because this can be done, this can be done in human laboratories. Why? Because whenever a heart attack is there in humans, they will generally do the NAG and GGT from the urine also and from the blood also, because GGT is exclusively, you all know, the liver specific enzyme, but when it is excreted from the glomerular cells, that is, when it is excreted from the glomerular cells, then it is definitely indicating of a renal damage. So this enzyme, NAG and GGT, is a very good indicator of urinary tubular damage. Then comes to the alkaline phosphate. So this is also a very indicator of early detection when the proximal part of the renal nephron it is damaged, breast border is damaged. So normally it is having the 5.8 IU per liter in terms of mmol of creatinine. When you have to compare this value of alkaline phosphate to creatinine, even at this 5.8, so it is normal. But in case of acute renal failure, 6.7. So 6.7 and 5.8, no measure difference. So renal dysfunction, not the chronic phase of renal dysfunction. So this can come in consideration if the facility available. We can go with this AKP, alkaline phosphate, GGT and NAG detection from the urine. It will be very much helpful for the earlier detection of the kidney dysfunction. Then a very important part, that is ultrasound. Majority of the clinics are having ultrasound facility and they are doing it. And as I told you, and I agree with all that, urinary, whenever the kidney dysfunction is there, whenever kidney is damaged, you can have some idea based on the ultrasound, because it is an ideal imaging test for evaluating kidney damage. It provides a very good information about the size, shape, any kind of internal structures as well as architecture of the kidney without harming patient. We are nothing to do with the patient. We are just doing from the externally. And the diseases can be diagnosed based on the ultrasound. Could be a diffuse if it is a nephritis or an end-stage kidney disease. If it is a regional like hydronephrosis or pyelonephritis or maybe the nephrolis, and focal or multifocal like a cyst or a polycystic kidney. So these kind of lesions we can identify by the ultrasound. And in any kidney disease, if the facility is available, then we should go for the ultrasound. We have the very good idea. So these are the pictures. We can measure the renal size, renal to vertebral length ratio, So these are the renal length. Vertebral length can be measured by this way, vertical line, and that has to be divided by the length of L5 or L6 vertebrae. This is an older method. If it is come between 1.3 to 2.7, it is considered as a normal. Nowadays, people are using the kidney aorta ratio, and that is also very important, where the vertical length of the kidney you have to measure, and it comes somewhere around 3.35 centimeter. Then you have to measure the length of aorta in this way, and when you examine aorta in this way, that can be identified aorta by copying the color from monitor. When you put the color CFM mode, you will find the red blue of illumination at this particular area, suggesting of aorta. But you should see that should be pulsating. If it is not pulsating, it is weighing. If it is aorta, it is pulsating. So when the maximum pulsation, you have to push and you have to measure this starting from this to this renal that aortic length. So it is somewhat about 0.85. So you have to divide the kidney length around by the aortic length. So it should come between 5.5 to 9.1 centimeter. So if it is below 5.5, it is suggesting of a shrinkage of kidney disease, maybe a chronic kidney disease. If it is greater than 9.1, it could be a hydronephrosis, it could be a nephritis. So this is very much important part of ultrasound, that you should measure the size of the renal. Then comes to the various pictures. This is a norm I have taken from the some of the reference articles as well. So these are the normal, some of the pictures are from our clinics also. So these are the pictures of a normal kidney. Where the left kidney, this is a normal picture of left kidney, you will see the very well appreciated medulla. This is a cortex, and that is the contour is very good. And you have the very good differentiation between cortex and medulla. That is a normal ideal image of the left kidney. Where here there is a no medullary border. You can see the hyperechoic medullary border. So it is suggesting of some kind of diffuse lesion, or maybe the echogenicity is higher. So that means that is indicative of some kind of inflammatory changes. And this is the picture from the leptospirosis, where you find the medullary band. Hyperechoic medullary band, you can see in this picture, it is indicating of a pyelonephritis, and it is seen in the leptospirosis. These are some other pictures of the kidney. This formula we should always remember: SLIC, that is S for spleen, Li for the liver, and CK for the cortex of kidney. So spleen is always hyperechoic, then the liver, and then the cortex of kidney. So if you want to compare the echogenicity of the liver, you should compare with the spleen. Then you can say it is a hyperechoic or a hypoechoic. If you if you want to have the echogenicity of the cortex of kidney, either you compare with the liver or you compare with the spleen. Then you can say it is a more hyperechoic or a less hyperechoic, or a hypoechoic. Like, so this SLIC, spleen is hyperechoic, then less hyperechoic is liver, and cortex is somewhat hypoechoic than the spleen. So in this picture you can see where there is the spleen is more hypoechoic, but the cortex of kidney is more hyperechoic. That is, inflammatory change takes place in the cortex of the kidney. So it is suggestive of some kind of inflammatory reaction takes place in the glomerulus nephrons, that may lead to a hyperechoic cortex. Otherwise, the cortex should be like this. It should be darker side, or it may be, if you compare these two images, in this image there is a hyperechoic cortex, here it is a normal cortex. Similarly, here you cannot have the differentiation between the cortex and medulla. Not well defined. Architecture is not well defined, right? And similarly, the cortex is also much more hyperechoic than the spleen. And this image, there is a hyperechoic medulla than the cortex. Otherwise, medulla is generally the anechoic or maybe the hypoechoic than the cortex. But here, the medullary sign it is there. It is suggesting of a renal fibrosis. Right, when the kidney is getting damaged chronically, develop fibrosis, at that time there is become hyperechoic. So this is very good information we'll have from the ultrasounds of the kidney. These are the images of the cyst in the kidney. anechoic area surrounded by the hyperechoic border. This is in the cortex. You may find this kind of cyst. That is a cortical cyst. If you find in the medulla here, that is a medullary cyst. And nephrolis. You can find the hyperechoic area in the kidney. It is indicating of a nephrolith. If there is a nephrolith, it is there. You will find the erythrocytic cast in the urine. So that is indicative of, yes, there is a nephrolith in the kidney. This is the image of the hydronephrosis where the renal pelvis is getting dilated. So that is very much clearly when you keep a probe, you will find the dilated renal pelvis indicating of an hydronephrosis. That may due to the urolith, or that may be due to the any kind of obstructive changes takes place in the urethra. So urine is accumulated in the renal pelvis and having the hyperechoic larger area. Then this image is of this all three image of an end-stage kidney where you can find the irregular border. You cannot able to differentiate where the cortex starts, where the cortex border it is there. So and it is having the irregular bus border. And echogenicity, you can see it is almost similar, right? So that's why it is a staging of end kidney, and this is a very classical picture of a chronic kidney dysfunction. You are nothing can be only you can see identify, yes, this is kidney, but medulla you cannot differentiate. The border or contour of the cortex cannot be well differentiated. So this is some indication of the chronic or end-stage kidney disease. And this last image, you may find the infractions. You may find the any kind of a renal mass or any kind of damage to this particular area. So you have to take a biopsy from this area and you can confirm what is actually there. So this is some very good image we can have, and we have information we can have from the ultrasound. Then we come to the nowadays the latest technique, that is Doppler ultrasonography. Of course, it is required experience. Of course, it is required patience for ultrasound, but there is very advanced stage. But we have very good information by a Doppler ultrasonography. If you have a sonography machine with the color flow monitoring and Doppler, at least you can do this thing. You can have the kidney image in center, then select the Doppler mode. You may find the color red and blue illumination from the kidney, that is indicating of a renal perfusion. Renal perfusion is good. You can have this idea. So this second image of a chronic kidney disease where I put the cursors over the renals. So there is no any kind of red blue illumination it is observed. That means there is a poor renal perfusion and stage kidney disease. So that is by looking to the image we can have the how much renal perfusion it is there. Next, then if you want to still measure, then it is called a resistive index and pulsatility index. Resistive index can be obtained by a Doppler wave. Just like in echocardiography, we'll have the peak systolic volume, that is peak systolic volume divided by the end systolic volume divided by the peak systolic volume. Then we'll have the value of the resistive index. Normally it should be 0.5 to 0.6. Maximum it is allowed 0.7. If resistive index is higher, it is indicating of a renal fibrosis, renal poor perfusion, and end stage of kidney disease. Same like a pulsatility index, that how much amount of blood is receiving and how much the pulse is getting generated. So that can be getting by the peak systolic volume, that is this, and end diastolic volume, this is value you can have, and ultimately you will have the mean of peak systolic volume. The value should be 1.52. If it is getting higher, then pulsatility is high, but it is not getting inside, right? And you have to take the cursor in the renal artery if it is visible. But intrarenal, where the medulla is located, you can keep your cursor and you will have the perfusion ideas about the kidney. So this is a very advanced stage of Doppler ultrasonography. You can try in your clinic if you have adult Doppler ultrasound. Then as I told you about the hyperphosphatemia, radiography can only help in these conditions in renal diseases. If there is a demineralization of bone and mineralization to the other tissue. Here you can find the excessive mineralizations, and this is a picture of a rubber jaw or the big head disease due to the hyperphosphatemia. And now ultimately the renal biopsy. So if you want to take a biopsy for a certain region, why it is substantial proteinuria, UPS is greater than 3.5, and unresponsive the anti-proteinuria therapy that you have followed, or any kind of suspected renal mass or the CKD in a young dog, we should take the renal biopsy. And before taking the renal biopsy, these are the general parameters you should take. The glucose, platelets, buccal mucosal bedding time in a systolic blood pressure should be in normal reference range. And with the use of ultrasound and biopsy needle, you can have the biopsy from the cortex only, or maybe the renal mass. Not you should enter in the much deeper because it will damage the renal vasculatures. Now comes to the acute and chronic renal dysfunction. Acute, if the abnormalities persist less than 3 months, any kind of abnormality, maybe in blood, urine, tissue, or imaging, if it is less than 3 months, it is acute kidney dysfunctions. So this is a guideline by the IRIS. We all know International Renal Interest Society has guided the creatine value, and they have divided the based on the creatine value. They have said the whether there is acute renal dysfunction is there or not, at what grade. If the creatine is less than 1.6, clinically that may be the oliguria, anuria, nausea, vomition, it is there, and elevation of other markers. If creatine is more than 1.6, you have to see whether clinical vomition, nausea is there, whether the elevation of other marker is there or not. If it is grade 2, it is from 1.7 to 2.5. At that time, you have checked the volume responsiveness. How volume responsiveness can be measured? So it is measured by the urine production. So if the urine, you have to, if kidney patient it is there, I would suggest you should admit the patient for at least 5 days. If you admit the patient for the 5 days, then you have the very good prognostic value, you have the very good control over the signs, and you have the judgmental data. So volume responsiveness can be measured by the urine volume production greater than 1 ml per kg per hour. If the base volume is 50 ml, then after 1 hour, if the production is, if 10 kg of dog produce the 10 ml of urine within hour, it is a very good sign that volume responsiveness is increased. At the same time, base value of creatinine maybe it is 1.5 or 1.7. Then if you do the creatine after 48 hours and it is greater than or equal to 0.3 milligram per deciliter increase, then it is progressive clinical disease that you have to take care about the kidney well, because it is progressing now. When it is cross 2.6, then it is the azotomic sign will exhibited, and up to the 10 there is a grading is available. So positive or recovery from the acute kidney dysfunction, it is based on the polyuric condition, or maybe the urine production increase and there is a decrease in serum creatinine from the baseline within 48 hours. If it is decrease and urine production of increase, that is a good volume responsiveness, good fluid therapy you have given, and it is a chance of recovery is also there. Then chronic kidney dysfunction, all will be there in case of greater than 3 months. It is no much differentiating point between that, but if it is approximately more than 3 months, it is considered as a chronic kidney disease. It is usually found in the older patient, but it is not always sure with the all ages. Now CKD, this is again given by the International Renal Interest Society, but it is now one addition is the SDMA, right? So if you want to do the SDMA at very earlier stage, and if you are able to do, then you can compare with the chronic kidney disease, whether it is a chronic stage of disease or acute kind of disease. But as there is a big confusion, if the nephron is damaged 25% and SDMA is detected, normal value of SDMA is 40 microgram per deciliter. But if it is elevated, maybe 18, how you can consider as a chronic kidney disease? That is a big debate going on. But still no answer, but it is suggestive by IRIS that if the value of SDMA is between 14 to 18, it is a grade 1 of CKD. And if the value is 1.4 to 2.8, it is having the SDMA value between this, and it is the mild systemic sign. And this all value, actually, this all value will tell you how the kidney is working. Otherwise, you have to always look for the patient for the clinical sign, dehydration, urine production. So it will tell you there should be a less uremic sign, less systemic sign that is indicative of a progressive or a regenerative diseases. Now some important differentiating point from the AKI to CKI when it is presented to us. So if we are not physical, this is all can be done. If we have, then we have the later stage, creatinine, burn, SDMA, urine parameters, all that. But by looking this, if there is an anorexia, lethargy and vomition, it could be an acute stage. If azotemia is present, then definitely a chronic stage of kidney disease it is there. In case of acute form, the water intake is initially reduced, then it is body condition is good. And in case of chronic, it is polyuria and polydipsia, because there is nothing is getting reabsorbed. So there is a polyuria, and to compensate the polyuria, there is a polydipsia. And there is a cachexic bone condition and weight loss. And finally, there is a kidney size, if it is normal or maybe the large with pain. But in chronic case, it is small, irregular, but no abdominal pain if you palpate physically. In hematology, the PCO is increased, non-anemia is there, but in chronic stage, it is a non-regenerative anemia, it is evident. In potassium, if we talk about in acute, it is normal to high, but in chronic kidney, it is mild hyperkalemia. But that is a culprit for the death in case of chronic kidney disease if you are not able to control the potassium level. Then phosphorus is usually high in both the cases of acute and chronic kidney dysfunction. If we talk about the urine specific gravity, if it is a pre-renal, it should be greater than 1.30, and if it is a renal origin, it should be less than 0.30 and up to the 1.008. In chronic, it is 1.008 to 0.15. So this is indicating of some kind of specific gravity is altered. That means it is having the kidney dysfunction. Apart from that, there are certain nephrotic syndrome. That is protein loose nephrotic syndrome, and there has to be differentiated from the glomerulonephritis. See, if there is a dog presented with us and you have seen the report, if the urea is normal, creatine is normal, phosphate is normal, protein may be a low or normal, but there is a ascites, hind leg or edema, or maybe a diarrhea, that is a nephrotic syndrome. That means this dog is still in acute form of the kidney disease. There is no glomerulonephritis developed. But along with that, if you find the urea creatine elevations, phosphate is elevations, then it is indicating of the glomerulonephritis. The nephron is getting damaged. But if urea creatine phosphorus is normal, then it is a nephrotic syndrome, and which is usually clinical exhibition is ascites, hind leg edema and diarrhea. But you have to always see the albumin level. Albumin level in urine, in the serum albumin, it is very low in case of nephrotic syndrome, and urine protein is high and specific gravity is low. Where in case of glomerulonephritis, it is somewhat low and protein is very much high. When the progressive disease of glomerulonephritis, protein is greater than +3, +4 in the diptych test. And specific gravity is normal to low, but it is a proteinuria. If it is a proteinuria disease, if it is a nephropathic syndrome, then the specific gravity is normal or it is raised, and there is a low albumin, and this urea creatine phosphate is normal range. So if ascites is there, then we should think for whether this parameter is normal. That doesn't mean that kidney is not damaged, but it is suggesting of nephrotic protein loose nephropathy. This nephron is damaged due to some other reason. We have to find that reason, correct this reason, ultimately the protein losing nephropathy will be corrected. Now comes to the very important part of the kidney dysfunction, that is treatment. And treatment, this is one abbreviation given by one of the scientists. Then treatment principle, you have to remember the nephron. Nephron has a different abbreviated form. N stands for management of nutrition, management of electrolytes, P for blood pressure, proteinuria and phosphorus, S for hydration, then retention of substances, any kind of other renal insult you have to avoid, management of neuroendocrine function and serial monitoring of the patient. These are the key principles for the treatment of the kidney disease. First, we come to the dehydration. Dehydration has to be measured by this standard table. We all know by PCT value you can have the dehydration. By the skin tenting you will have the idea of dehydration, or with the capillary refill time we will have the idea of dehydration. And finally, when you have calculated that, in the each and every patient you have to flush IV catheter when it is presented to you, because it is getting more dehydrated in later days. So then it is difficult to get the vein. So it is better you will have, when it is presented to you, place the IV catheter and place the urinary catheter if you are admitting the patient. So that will give you about the urine output. If the urine output, because urine output is ultimately important for the improvement of glomerular filtration rate. So this too is essential. Place the IV cannula as well as the urinary catheter in male and female both. And a fluid depletion volume, that is by the percentage of dehydration, 40 weight in kg, that we all know. And 5% dehydration is always present when kidney damage has been started. There is always, as a thumb rule, there is a 5% dehydration, and it has to be replaced within 2 to 4%. That means your fluid therapy is immediately you should start for whenever kidney patient is presented to us. After fluid replacement calculation, you should maintain the fluid at the 44 to 66 ml per kg per day. And choice of fluid should be the Ringer's lactate if there is not a hyperkalemia. And if it is a hyperkalemia, you can give with the sodium chloride, 0.9% sodium chloride. You should flush the kidney and you should give the fluid therapy. For the flushing the kidney, fluid therapy is the key role. The n number of hydration status you corrected, ultimately the glomerular filtration rate is increased, ultimately the urine production is increased, and ultimately if the urine production is increased, the excretion of the potassium, excretion of the phosphorus and other blood urea nitrogen is getting excreted, and ultimately the clinical signs, uremic sign is decreased. So after doing correction of fluid therapy, after doing the normotensive or a normovolemic patient, still if there is no urination. For trying, you give the 10 ml per kg intravenous crystalloid. If still there is no urine output, you have to first see the urine output by the fluid therapy. If there is no urine output, after replacement fluid therapy, if there is no urine output, then again give 10 ml per kg intravenously, wait for the 30 minutes. If there is no urine output, then you should go with the diuresis. It is must. Then how we can manage the diuresis? Through the oliguria and urea. When fluid therapy is initiated, I should tell the urine, normally you should increase the 2 ml per kg body weight per hour. If it is not increased, it is oliguric, and you should start with the furosemide. Furosemide is the loop diuretic first choice because it is not altering the glomerular filtration rate. It is just flushing the kidney, passing the urine, and it has the vasodilatory effects and inhibit the sodium, chloride and potassium pump in the luminal cell of loop of Henle, where it is getting accumulated and reabsorption has been takes place. So it is getting clear it when it is excretion has been started. The dose, standard dose is 2 mg per kg for intravenously. You have to give, wait for 30 minutes. The urine has to be there. If it is not there, then you should escalate the dose at 4 to 6 mg per kg body weight after 6 hours. And if urine is there, then you should maintain the patient with the continuous rate of infusion for next 24 hours. Right? Because the next polyuria has to be initiated for excretion of potassium, phosphorus and the metabolic fast. So CRI should be given at 0.66 mg per kg body weight per hour. Then 20% mannitol can be also be used for using osmotic diuresis. It helps in extracellular volume expansion and renal absorption by acting on renal angiotensin. It is act as antagonist, so renal absorption has been stopped. So there is a renal sodium retention will stop. Ultimately, osmolarity has been maintained, and the fluid hydration status will be maintained. It has can be given at the 0.5 to 1 gram per kg, because we all know that 20% mannitol it is available. It is to be given 0.5 to 1 gram in within 20 minutes. You have to give, urine flow should be there. Urine flow should be there within hours. It should be increased. And if it is increased, you can repeat it at the 6 hours, or you can set continuous rate of infusion at 1 milligram per kg per minute intravenously. If the what we call that furosemide, if it is not working well, you can switch over to the osmotic diuretic, is the second choice. Then if it is not available, you can use the 20% dextrose at the dose rate of 22 to 66 ml per kg per day. At the dose rate of 2 to 10 ml per minute, you have to have the infusion rate. And you should always think, if there is a oliguric but it is volume overhydrated, if it is a pulmonary edema, if it is an ascites, then you should not use the mannitol. You should use the furosemide. Or the severely dehydrated cachexic patient, then again you should not use the mannitol. You should use the furosemide. Then balance of electrolyte, because hydrogen ion, it is getting retention from the distal convoluted tubule, it will increase the metabolic acidosis. So if you have the facility for the measurement of SCO3 blood pH, then you should do it and see what the blood pH, if it is less than 7.2 and bicarbonate SCO3 level it is less than 14 MEq per liter, then you should start the metabolic acidity, until unless it is actually not required. But still, if you find the urine pH is very low, urine pH is less than 5, then definitely the blood pH is getting low. At that time, you can start like either calculating SCO3. If you have the value of SCO3, then you can calculate actual deficient, that is body weight in kg. 0.3 is the standard correcting factor, and 24 is the standard base deficient. Then if you have the idea, if you have the actual value of SCO3 which is there, you can put over here in place of 24. But if you don't have value, you can calculate by keeping 24 multiplied by 0.3 and body weight in kg. You will have the actual, the base deficient, and you can give. And if you don't want to go in this calculation, roughly you can start 8.4% solution MPL of 10 ml it is available. You might have all know 8.4% sodium bicarbonate MPL it is available. You have to give 1 ml of 8.4% solution per kg body weight over 30 minutes. And this 1/4 or 1 second dose can be given slowly, directly, slowly, and remaining calculated dose can be given over the 4 to 6 hours in intravenous fluid. You have to dilute this with the normal saline. So that will correct the metabolic acidosis, and ultimately if the correction of metabolic acidosis is there, the patient may feel better, the nausea will be less, the appetite may also increase. And renal excretion of potassium, it is very much essential. Potassium you have to eliminate from the body. Generally, if you are not able to eliminate it, it will show the cardiac abnormality, and it is life-threatening. I tell you, in the chronic kidney disease, that is due to the hyperkalemia. 1 MEQ of the potassium, it is increased, decrease the 1% survival rate. It is quoted by some of the scientists. 1% survival is decreased, 1% decrease of 1 MEQ per deciliter of potassium. So it is a life-threatening. If you take the ECG, if you are expecting hyperkalemia, right, then it should have a bradycardia, tall and spiked T wave, shortened QT intervals, wide QRS complex, and P-wave abnormality. If it is there in the ECG, it is suggesting it is having the cardiac effect, the hyperkalemia having the effect on the cardiac muscle. Then you should start with the insulin, any insulin, short-acting insulin. Human insulin you can use 0.5 unit per kg body weight intravenously, followed by dextrose. You should give the dextrose, because when you give the insulin, body may not have the glucose, right? Because it's not taking the diet. So you have to provide the dextrose, you have to provide the glucose. How much? 2 gram per unit of insulin. That means if you are giving a 1 unit, then you have to give a 4 gram of insulin. Then 2 gram, how much it is measured? If you give a 40 ml of 5% dextrose, then it is suggested that it is equally like the 2 gram of dextrose. So you have to give the 2 gram of dextrose per unit of insulin. So that will immediately excrete the calcium. That will, the mechanism called the exchange of sodium, exchange of bicarbonate, then there is the excretion of the potassium. So that will take place. And apart from that, you should give the 10% calcium gluconate. 0.5 to 1 ml, 10% calcium gluconate ampule, 10 ml ampule, it is available. You have to give 0.5 to 1 ml per kg slow IV. If you do this insulin, dextrose and calcium gluconate, within a minute cardiac abnormality will be subsided. So this is a very good protocol to stabilize the cardiac abnormality due to the hyperkalemia. So if it is presented to us having this much kind of cardiac abnormality, do this, it will restore the abnormality within a minute. Then phosphate, you have to always control the phosphate. Along with the phosphate, there is a hypocalcemia we have seen in the picture of hyperphosphatemia. So these are the list of the commercially available preparations. In India, we have available Ifakitin powder. You will all know it is available there. It is having the chitosan and calcium carbonate, can be given at 1 gram or 5 kg twice daily. If the animal is taking, you can have the diluted, or you can have the nasogastric infusion. You can give this twice daily. So that will reduce it will bind to the potassium, and it will decrease its serum potassium level, as well as increase the calcium level in the body. Ultimately, the renal hyperparathyroidism which is there, it is decreased, and ultimately there is a mineralization, that is called a demineralization of bone, and mineralization it is reduced. So phosphate binder is essential to start, but it has certain caption when to start the phosphate binder. Phosphate binder can be started when the calcium level is low. If it is a hypercalcemia, then should not start the phosphate binder. right? You should not start the phosphate binder if there is a hypercalcemia. That's why, because you give, it's a calcium carbonate already, so it will more add to the calcium, that is detrimental to the kidney, and it will cause the renal fibrosis more. So you should have the phosphate binder when there is a low calcium. Then neuroendocrine function, that we all talk, renal hyperparathyroidism, that can be managed. If there is a hypercalcemia is not there, hyperphosphatemia is not there, then and then only you can give the calcitriol. It is less practice in the field condition calcitriol, but if there is a what was called demineralization of bone, it is exhibited, rubber jaw is exhibited, but if you settle the hyperphosphatemia and hypercalcemia, then and then you can start the calcitriol. Injectable calcitriol is also available, and oral calcitriol sachet is also available. You can go with 2 to 3 nanogram per kg per day, but it is less practicing in our field condition, particularly doc. Now comes to the anemia, which is common. Hyperproliferative anemia is a hallmark of kidney dysfunction. When you find the anemia, there's definitely a kidney dysfunction is there, and it is shown that if the PCV is 35%, the survivability is high. If the high PCV value is there, then the survivability is much more high. If the good PCV value, you can have the fluid therapy. If the less PCV, less RBC, less HB, you cannot have the much more fluid therapy. So you have to start the erythropoietin. Injectable recombinant human erythropoietin is commercially available in 2000 IU to 4000 IU in market of a human preparation of, it can be given at 100 IU per kg body weight, subcutaneously thrice in a day. You have to give 3 times in a day. But if you have a darbepoetin, it is also a human product, long-acting erythropoietin, that can be used as a 1 microgram per kg body weight, and it can be given subcut once in a week. So if you have the darbepoetin, it is less side effect and longer effect. So it is better to use in any kind of anemic patient. If you find not only kidney, if any kind of anemia, and if there is a kidney is damaged, then you can use of this product of erythropoietin and darbepoetin. Then blood pressure is a very important part. As I tell you, if the sodium retention will be there, the pressure is naturally high due to the RAS system. So you have to control the blood pressure. If you are not able to control the blood pressure, the percentility index is high, but the renal perfusion is poor. Right. So at that time, you have to see, this is another guideline. If there is a less than 150, it is a normotensive. This is a diastolic pressure. If there is a high, the low risk at up to 150, and it is high risk if the blood pressure, systolic blood pressure is greater than 180. Systolic blood pressure is greater than 180, you should start the what we call antihypotensive therapy. If you don't start, the patient may die. Right. So due to the cardiac abnormalities and the cardiac arrest. So the blood pressure has to be managed in the kidney patient, and these are the breed specific range. If you have any kind of breed specific range, so this is to be consideration, but this value is important. Systolic value is much more important. Then comes to the how we can manage the blood pressures. See, these are the two preparations, benzalapine and enalapril. This is called SE inhibitors. It is commonly used, available in oral form. Human drug, 0.5 milligram per kg body weight, give per day. You can give orally, or you can divide into the morning evening session also. So if after giving 2 to 3 days, check the blood pressures. If it is getting reduced, if it is not reduced, you can escalate the dose up to 2 milligram per kg body weight. In spite of giving this benzalapine and enalapril, if the blood pressure is not controlled, then you have to give the calcium channel blocker. Calcium channel blocker will work well, that is amlodipine, that at the dose rate of 0.1 to 0.3 milligram per kg body weight, along with SE inhibitor, it will work well, right? So these are the list of the drug. Losartan is generally not used. Telmisartan 1 milligram, that is a angiotensin receptor blocker. But this all drug you have to use when the patient is hydrated. You have to make the patient well hydrated, because if you are not hydrating the patient, the blood pressure ultimately not increase, and it is having the negative effect. So you have to hydrate the patient well, then give the blood pills, and that pills will improve the control the blood pressure as well as the proteinuria. Because whenever the hypertension is there, high pressure over the glomerulus, so there is the permeability is altered, so proteinuria will leak. So for the management of proteinuria and management of hypertension, this SE inhibitors working well. Then it has been said that essential amino acid, if you are providing to the patient of kidney, then it will help in utilizing excessive nitrogen are there in the circulations. So either you give the oral amino acid preparation or you give the intravenous. So this is a Hermin, it is available of human Hermin intravenous 200 ml intravenous preparation is available. You can give, if it is less than 30 kg, you can give 100 ml. If it is more than 30 kg, you can give a 200 ml intravenously to be repeated every 3 days. And if the animal is taking diet, then you can have the oral tablet having Hermin 4, and it is both is commercially available in India in human medicine. So it will very well helpful to reducing the burn value. If the burn value is reduced, ultimately uremic sign is reduced, and uremic sign is reduced, the patient having the very good effect. Now comes to the gastrointestinopathy. This is very common in case of kidney dysfunction, vomiting. We are treating with here with the ondansetron 0.5 milligram per kg body weight intravenously, but you have to start at every 6 hours. That's why the admitting patient is must. If you are not admitting patient, then you cannot give the every 6 hours, every 8 hours. Metoclopramide, if it is a diarrhea, you should avoid the metoclopramide because it increases the duodenal motilities. But ondansetron can very well control the vomiting. You can give at 0.5 milligram per kg body weight intravenously. It is available in human medicine. Meropetent, it's a very excellent drug. Many vet practitioners import this drug from the foreign market because this drug is not available in Indian market. And meropetent is a very good drug available in Indian market. Has a very good potent anti-emetic, having some sedative effect also. Can be given at 1 milligram per kg body weight. Subcut, and benefit is that it can be given subcut also, and it can be given SID, single in a day. Not a 2 times or 3 times it is required, but it should be used less than 5 days. If it is not vomiting control for the 5 days, you should switch over to another composition, that is ondansetron. Then gastric ulcer is also there because whenever there is a nephrotic signs, it is there. Whenever there is a uremic signs, the toxin is accumulated in the particular of room, a particular mucosa of the stomach, and that toxin getting ulcer over there. So that is a sign there is a gastric ulcer. So you can control by giving the omeprazole or pantoprazole at 1 milligram per kg body weight intravenously, single in a day, will well control over the gastric ulcer. If it is not vomiting, then you can give a sucral fat, will masking the ulcer at the dose of 0.5 to 1 gram per kg body weight orally. Now, last part, that is a nutritional management of the kidney patient. You have to always protein restricted. But when protein is to be restricted? When the burn is greater than 80 and high phosphorus and creatinine is 2.5. At that time, you should advise honor to restriction of the protein. And when the renal diet is advisable, when the CKD stage 3 or 4 and proteinuria it is there, at that time you have to advise the renal diet. And you should give the sufficient calories to stop the protein catabolism. So it has been said that 70 kilocalorie per kg body weight you can give. You can prepare a homemade diet, or you will have the commercially available diet. And in this next slide, I will tell you this is a homemade diet. It is available, right? Broad test, cheese, egg, cooks, whole mix. It is giving the value. You can calculate according to this value, according to this body requirement, and you can give it. So it will very much helpful to the patient if you give the sufficient calorie diet. And no sodium restriction is required, because if you restrict the sodium, ultimately sodium is less absorbed, and if you excessively give the sodium, it is having the detrimental effect. So there is no sodium restriction is advisable in the kidney patients. And supplementation of omega-3 PUFA, it is documented having the renoprotective and anti-inflammatory properties in kidney dysfunctions. So omega-3 is beneficial. You supply orally to the patients. And many spray form omega-3, it is also available in veterinary as well as the human market. You can use it. And commercially available wet renal diet rather than the dry renal diet, it is preferable. And last, and less practicing what we call a therapy, that is renal replacement therapy. That is it is when it is useful, when medical management plan. In spite of all that we have discussed, we have tried, but the animal is not responding. At that time, the renal replacement therapy we should start when there is a severe hyperkalemia and hyperphosphatemia, when extremely presence of uremic signs, and patient with the acute kidney dysfunction or it is more appropriate than acute kidney dysfunction than the chronic kidney dysfunction. But renal replacement can extend longevity for a few months, provide a well-being of kidney at the high cost. And this is generally a peritoneal dialysis and extracorporeal renal replacement therapy. These are two recently available techniques that we can use. Peritoneal dialysis can be done by use of peritoneal catheter. You have to insert in the peritoneum from the that particular navel cord, keeping 1 to 2 centimeter away from the navel cord, insert in the peritoneum, and you have to give the peritoneal dialyzer inside, keep it for 1 to 2 hours, and you have to drain the solution. So the solute will be drained due to the change of osmolarity, and you have to repeat this process 2 to 3 times in a week. So if you don't have the peritoneal dialyzer, then you can use the Ringer's lactate solution also up to the 1 liter. You have to insert in the abdominal cavity, peritoneal cavity, wait for 2 hours and withdraw. But the risk of peritonitis, risk of sepsis is much more in case of peritoneal dialysis. Then ultimately, that is a hemodialysis. So these are the real photograph that we have performed the intermittent hemodialysis in dog in April 2019. We are thankful to the Dr. Kasturi Barur from the Veterinary College Bombay. He has demonstrated well at our clinics, and nowadays we also started in 2 of dog. We had performed the dialysis in our clinic also. And it has a very good result immediately because it will reduce the 50% of the whatever getting deposited in the body in single dialysis, right? So that's why it is having the very good effect over the uremic signs, over the hyperkalemia, hyperphosphatemia. But you have to repeat the process 2 to 3 times in a week according to the available parameters. And these are the very advanced CRTT unit, that is continuous renal replacement therapy unit, commercially available in human medicine, and few of veterinary colleges are also having these CRT units. Now ultimately the prognosis. In spite of all this, the 60% of dog is getting died or is humanly euthanized due to the failure of poor management. Even though the 80% of dog is treated with hemodialysis, it has a more survival. And infectious disease, the 40% dog can survive well. So decreased urine production and hyperkalemia are the poor prognostic factor in dogs with a poor dysfunction, kidney dysfunction. And mean survival time is 226 days of kidney patient. How much long it will live? So maximum it can be live at the 226 days based on the IRIS stages of the guideline. So friends, this is end of my seminar. This is some important conclusion. We all know that it plays a vital role in regulations. Geriatric patients are more urinary markers like microalbuminuria, CRP, NAG, GGT are sensitive markers other than serum like one created except the that particular SDMA. And hyperkalemia, hyperphosphatemia are consistent finding in any kind of chronic kidney disease. Ultrasonography is very much helpful. Iris staging can helpful theoretically to diagnose the various stages of the kidney and to prognosis of the kidney dysfunction. And principal nephron is to be adopted for a better therapeutics. Thank you so much for kind attention for I think more than 1 hour 45 minutes. Now I request Modi sir to continue the session.
Thank you, Dr. Sudhir, for giving a very beautiful presentation with all the information. Thank you. Sorry, some equally there. Wait.
Somebody in the chat box written there is no audio, but I think audio will be audio was there throughout the session.
It is okay, Dr. Sudhir, it is okay.
Okay, fine. You can continue, sir.
So, thank you, Dr. Sudhir, for giving a very beautiful presentation with all the information, which will be very helpful in field condition. So, for question and answer session, I request Dr. Vilona to please handle the question and answer session. Dr. Vilona?
Yeah, thank you, sir. Am I audible, sir?
Yes.
Yeah. There's a question by Dr. Pragnesh. So, what is your opinion about kidney-specific diets and some products like ipakitin by vetoquinol? And is there any natural herbs which is really useful for kidney-compromised patients?
Okay. Regarding kidney diet, I suggest that if it is a grade 3 or grade 4 CKD patient, according to the grading it is given in the slide, you should start the renal diet. Regarding ifakitin, if there is a hyperphosphatemia, then and then you have to start, but at the same time there should not be a hypercalcemia. And regarding vetoquinol, only very good product available by that company, ifakitin, that can be very well used, and it has very good effect also on the phosphate control. And the third thing you have asked about the
natural herbs, sir.
Yes, natural herbs. There are certain companies producing the natural herbs which definitely improve that prevent the fibrosis in the kidney, renal medulla. That will prevent the fibrosis and will definitely help. But again, you have to stabilize the other parameters like vomiting. First, you have to control. You have to control the potassium. You have to control the phosphorus. If it is controlled, then you can switch over to the herbal formulation. Then if animal started taking something, then you can start with herbal formulation. Otherwise, it is difficult, not much helpful.
Okay, thank you, sir. Next question is by Dr. Jay. What are the histopathological findings in acute and chronic kidney diseases?
Actually, sir, I don't have much idea about the histopathological finding, but I not give much answer because I have not covered, even I have not any time studied particularly histopathologically what is there. I always look for clinically other parameters there. So sorry for not answering the question.
Thank you, sir. Next question is by Dr. Pragnesh. How dopamine decreases serum creatinine? Is it advisable to use for a dog?
Dopamine is not advisable to use in the dog because it may have the effect on the hypertension. So you should avoid this drug to use in the dog.
Okay, thank you, sir. The next question is by Dr. Mayankar. We are able to diagnose diabetes mellitus by human glucometer?
Yes, very well used human glucometer. I should say every clinic should have the human glucometer. It has same value like the human. So we can have the drop of the any kind of arterial or peripheral blood. You will have the result immediately within second, and you will have it is more than 100. Then you should think of it is more than 200. Then definitely it is a diabetes mellitus.
Yeah, thank you, sir. Next question is by Dr. Arti. Dog voiding urine that dries off and jet granular. What could be the possible diagnosis, and can it be managed with just diet?
Please repeat the question, Ilona.
She has asked if dog is voiding urine that dries off and jet, I think maybe gel granular. So what could be the possible diagnosis, and if it can be managed with just diet?
If it is drying off very immediately, the specific gravity must be the high. The protein will be there. So the high protein diet like eggs, right? The other protein restriction is advisable, but protein of high biological value, that is particularly egg, you should give morning and evening. You should see if there is a change. First you have to check whether there is a proteinuria is there or not. If it is there, you start with the egg. You can start with the even renal diet. You can start, if there is nothing harm to start renal diet. Of course, theoretically it is suggested grade 3 to 4, but you can start it if there is a proteinuric disease, because proteinuria, when it is evident, at that time renal diet has to be started. So that can be managed by eggs or renal diet if the protein is there, because drying is earlier.
Okay, thank you, sir. Next question is by Dr. Jignesh Parmar. Is there availability of stem cell for kidney damage?
Yes, Madras Veterinary College is trying regenerative medicine cells. Whole unit is there, regenerative medicines, and they are trying to even renal transplant also in nearby future. But nowadays in India, according to my knowledge, nobody has performed a stem cell therapy for the kidney. Even Madras Veterinary College also, they are trying and working on that.
Okay, thank you. Next question is by Dr. Jay. Any kidney disease?
Pardon, please repeat.
Is there any correlation between blood pressure and kidney disease?
Of course, if there is, that must be whenever you are expecting kidney disease, you should check the blood pressure by either multipara monitor or the sphygmomanometer. This is available for our vet, oscillometer, it is available for the vet. You should always check, because whenever there is a high blood pressure, that will indicate there is a poor renal perfusion. So if there is a poor renal perfusion, ultimately what we call a RAS, renin-angiotensin activation system, it is there. So it will getting imbalanced. You have to control the pressure for control of kidney disease, and for that you have to give a SE inhibitors, angiotensin blocker or a calcium channel blocker. So there is definitely relationship with the kidney hypertension as well as the blood pressure.
Thank you, sir. Next question is by Dr. Rajender. Should we use dopamine when metoclopramide is given as an antiemetic?
Right now, I think any literature is not suggesting dopamine to be used, because it has some effect on the blood pressure, as well as it has some effect, poor sepsis, poor emesis effect, antiemetic effect over the gastrics and exhibited by dog in kidney patient. So they recommended ondansetron, metoclopramide, or maybe the meropenem, which I have discussed.
Okay, thank you, sir. Next question is by Dr. Manish. Is rectal dialysis solution available for humans or are helpful to decrease uremia?
Rectal dialysis.
Yeah.
Okay. So many times it has been done, but very, very rare it has been performed in our veterinary patient, because it may have some kind of what we call complications, because animal you have to insert something, dialyzer or a solute, you have to insert regulation of the patients. So it is somewhat difficult to the veterinary patient. So rather than going for rectal dialysis, I would suggest you can, at the field level, you can do even peritoneal dialysis, because that dog is not having, if it is not recovering from the clinical signs, then if we talk about the renal medical management fund, then you can start for the peritoneal dialysis. Insert any kind of peritoneal catheter costing only 400-500 rupees. It is available. Human catheter we have to use. You can directly insert, fill Ranger lactate, wait for 2 hours and remove, and keep the catheter having stitch over there. Keep it for a week, and you will have the better result of the peritoneal dialysis rather than the rectal dialysis. It is having complications and difficulty to perform in veterinary patient.
Okay, thank you, sir. Next question is by Dr. Sharon. Is there any equipment available for hemodialysis in India?
Yes, of course. I have shown the photographs. The human, actually, there is no specific instrument for the medical, that our veterinary patients, for dog. It is only the instrument we are using for the human patients that I have shown in the photographs last slide. So these are the that called intermittent hemodialytic unit. I will show you. I think I have the photos. Wait for a minute. So these are the instrument. That is a company called the Fresenius has developed a very good intermittent hemodialysis unit. It is commercially available in India. Each and every human the dialysis unit are having a number of this unit, but few veterinary colleges are having this dialysis unit. And this one is the most advanced, that is for a continuous renal replacement therapy. It is with the very, I think 1 or 2 veterinary colleges are having this, but both are available in India. You will have some practice on this techniques, then you can do it your clinics also.
Yeah, thank you, sir. Next question by Dr. Varinder. What are the benefits of using clopidogrel in renal patients?
No idea, sir. I don't have heard about this content.
Okay, thank you, sir. I'll just take one last question by Dr. Anjali. What should be the treatment and precautions in case of urinary bladder tumor?
Okay, urinary bladder tumor, then that should be, it could be a transitional cell carcinoma. You have to always take care. Well, it can be determined by the ultrasound, it can be determined by the urine analysis. And regarding care, if definitely the urine bladder tumor is there, then there will be a difficulty in urination, maybe pain in urination, or maybe the withholding of urine. So if the animal is not urinating, you have to pass the catheter, keep the catheter, and better to remove the tumor if it is possible. And if it is not detrimental, animal is urinating, you should restrict the protein diet. Because it may ultimately damage accumulating urine, ultimately accumulate the solute, and ultimately that may have the kidney dysfunction. You can have the eggs, You can have to prevent the sepsis, you will have the antibiotic course for at least 7 days. And better to remove if it is detrimental effects over the animals. If it is not, keep it. You will manage with the diet, manage the sepsis and pH of the urine, and there is no blood, then you can continue with the tumor, and if it is damaging, then you should remove the tumor.
Okay, sir. I'll take one last question by Dr. Jay. Is kidney replacement possible in dog? And if yes, what is the successful rate?
So right now, kidney replacement, it is there in foreign countries also. In India, nobody is doing the renal replacement, but it is having the very good success rate, because during my preparation of these seminars and as well as during my student is also working that we have seen the renal replacement therapies, renal replacement procedures. So it has a very good success rate, but the compatibility has to be made before transplantations. Right? Just like in human, we have to make the compatibility of the kidney, and that's it make difficult because the different breed kidney, the donor is not available. Right? The availability of the donor is the major issue. Second, the compatibility, because it has been said that if the kidney is of a same blood, then the compatibility is higher. But if the compatibility is poor, after transplantation, there is a lot of complications. So in India, it is at now not possible. In foreign, that is also not possible. It's possible, but doing very rare, because donor availability of the donor, and there is a poor compatibility, because there is no bloodline available or a bloodline data is available, then nobody is going to be donate. Like in human, if my wife kidney is damaged, then I may donate, or her mother can donate. But like in other dog, it is not well possible. So renal transplantation is still a growing field, and is the future of CKD patient. May have in future that the donor of the kidney is available, and we can the dog may have the new kidney.
Okay, thank you so much, sir. That's all, sir. I would like Dr. L.C. Modi, sir, to take over, please.
Thank you, Dr. Vilona. Thank you, Dr. Sudhir.
Thank you so much.
So much. A very long session of at least 2 hours, and a very good presentation by Dr. Sudhir, and also clear the doubts of the participants. Dr. Sudhir, I have one question.
Yes, please.
So, in nutshell, what you advise to our field vets regarding kidney failure?
Whenever you are expecting general clinical sign, you should go for first urine analysis, because it is a very good indicator of a kidney dysfunction. And if urine abnormality is detected, then you can switch over to the serum creatinine and burn. But don't rely on serum creatinine burn. Rely on the UPC, rely on the microalbuminuria. And if possible, do the marker that we have suggested.
Thank you, Dr. Sudhir. So at the end of the webinar, I request my colleague, Dr. Deepak Suthar, Organizing Secretary of this webinar series, for a vote of thanks. Dr. Deepak, please.
Thank you, Dr. Lalit Modi. Thanks to all the participants this joined with us, and we are thankful to the authority of the NAO, the Honorable Vice Chancellor Sir, Dr. S.R. Chaudhary Sir, the Dean of the Veterinary College, Dr. V.B. Kharadi Sir, and Director of the IT, Dr. H.R. Pandya Sir, for the positives and strong support of this webinar, the series. I am also thankful to the department, team of the IT departments, provide the digital platform of the NAU e-learnings. And I am also thankful to today's speakers, Dr. Sudhir, for accepting our invitations and delivering the nice presentations and excellent explanations, justified these topics. Dr. Sudhir, thank you very much to the.
Thank you, sir.
And I am also thankful to my friend and Dr. Lalit Modi as a co-organizer secretary, is giving the support and always with me. Once again, I am thankful to all the participants who joined with us, and this whole PPT will be sent in your emails. So please send your email on Dr. Dan Wait community at gmail.com. So whole PPT will be shared. Finally, so next week I will meet with the new speaker with the new topics. So till then, namaskars and goodbye.
Thank you, sir.
Thank you.